So, we are going through the development of the GI system. We learned this particular GI tract exists from this oral cavity to the anal canal, has got two opening, oral cavity opening which is known as mouth and anal opening, anus. In between this we have organs, we have tubes, we call them as GI tube or GI tubes have got different names, small intestine, large intestine, stomach, esophagus, etc., and sigmoid colon which ends into rectum and anal canal. It has a lot of organs in this part, especially in the upper part of the abdomen like the liver, gallbladder, and as well as pancreas, and a placed organ which is placed in the GI system but not a part of the GI developmental content, we call them a spleen, that is also present in here. So, we have started about this particular developmental journey starting with this particular yolk sac. That particular sac exists as a sac initially, then this sac contributes to formation of the tube, we call them as primitive gut tube. That particular primitive gut tube gives rise to the three segments of this particular primitive gut, we call them as foregut, midgut and hindgut. Foregut which is present in this particular forepart or head fold region, hindgut lying on this tail fold region, and in between which is connected to this particular tract, we call them as vitalointestinal duct. That particular duct is present as a midgut. Each of them have got their separate blood supply to it, which is supplied through the celiac trunk, SMA, IMA, which are different branch which is going to supply this particular system. They have a mesentery to be attached in this part, we call them as ventral and the dorsal. Ventral one is short lived, does not have much, and even this particular ventral which is shortly present have got modifications. Part of this is encroached by this particular lever, becomes this particular falciparum ligament, and the back side which is known as the lesser omentum. Thus posterior omentum which is known as this dorsal mesentery, which is present extensively throughout this particular GI tube, we call them as dorsal mesogastrium, mesoduodenum, mesentery proper, and dorsal mesocolon. Likewise, this particular element is there, and this is what we are talking about: celiac trunk, superior mesenteric artery, inferior mesenteric artery, feeding this particular primitive foregut tube, midgut tube, and hindgut tube. Now, we have briefly started about development of this particular foregut derivative, started with esophagus. We started about esophagus, which is a tube which is communicating with this oral cavity to this particular stomach. Then this particular esophagus have got like things that you should keep in mind. It has a diverticulum or pouch that goes in here. We call them a respiratory diverticulum or lung part, which splits into right and left. Now, thing is, with this part we have to know there should have a partition between this particular developing esophagus and developing respiratory diverticulum. We call them as tracheoesophageal groove, which becomes this particular septum, and if septum fails to develop, we have a communication between them that creates a lot of clinical problem, which is known as this asphyxia, etc., which affects the newborn. We learn about that. Then we move to this particular further tube, we call them a stomach and stomach development. Now, beyond this particular esophagus that is going on, this particular stomach is going to grow. Now, there is a kind of like a surprising thing in terms of this particular stomach happens whenever it is going to develop. Now, you see that this particular stomach tube was initially is a tube just like any other tube, that's just like esophagus tube. Now, this particular stomach has got attached to it this particular mesentery. We talked about this mesentery which is known as ventral mesentery, anterior one, and the posterior one we call them as dorsal mesentery. That's what we agreed to. Right side to it we have a nerve climbing down, we call them as vagus nerve. Right side and left side we have two nerves, right vagus and left vagus, which is going down on this particular right and left borders of this particular stomach. So, this is how this particular stomach was initially placed. There is nothing different with it. Now, as the time progresses beyond this particular 4th week of life, the stomach have got two walls, anterior wall and posterior wall, which has got attached with this mesentery, ventral mesentery and dorsal mesentery. It has a disproportionate growth that shows in here. What do you mean by disproportionate growth? One grows more, other one grows less. This kind of growth we call them as disproportionate growth of the walls of the stomach. Now, what happens if you have a disproportionate growth? The posterior wall of the stomach grows more than that of anterior wall. That means the posterior wall is growing at a greater speed than that of anterior wall. And as a result of that, the posterior wall of the stomach becomes bulkier, becomes fusiformly dilated, becomes more dilated than the anterior wall. So, we call this particular phenomenon as disproportionate growth of the organ. So, that is what we have to keep in mind or understand out here. We call them as disproportionate growth of the walls of the stomach. Now, as a result of this particular disproportionate growth, what happens? Posterior wall of the stomach becomes heavy and anterior wall becomes less. That creates the two curvature, that what we are calling here. We have more curved region and less curved region, which has starting to develop. So, as you have seen this particular adult stomach, which has got like two curvatures, right? So, we have this particular more curved, great curved and less curved. We call them as greater curvature of the stomach, lesser curvature of the stomach. So, this greater and lesser curvature has formed because of this phenomenon. Disproportionate growth of the walls of the stomach. Which wall? Anterior wall and posterior wall. The posterior wall growth is more than anterior wall. That is why this particular thing has happened. So, this particular stomach is posteriorly more curved. We have a greater curved region on the back side, and anteriorly it has less curved. We have lesser curvature anteriorly placed. And again, onto that, we have two things present in here. We have this vagus nerve, right side, right border, left side, left border. We have the right and left vagus here. Now, after this particular disproportion growth, there is this other thing happens, or other new thing happens to the stomach. What happens here? We have a rotation of the stomach takes place. So, we have a second phenomenon in here develops here. We call them as rotation of stomach. So, what do you mean by the rotation of the stomach? The stomach moves, stomach rotates. Now, there are two kinds of rotation there. The rotation of the stomach takes place into two axes. We call them as rotation number A, we call them as longitudinal axis rotation. There is a second rotation which takes place, B, we call them as anterior posterior axis rotation. There are two phenomena that happens to occur after this particular stomach has assumed these two disproportionate growth. It starts to have a movement. That particular movement we call them as rotation of stomach. One rotation which takes place around the longitudinal axis. That means the stomach is pierced above down and then stomach rotates. If that rotation happens, we call them as longitudinal axis rotation. The second type of rotation is there, stomach is pierced front to back and then it is tilted right and left like this. So, this kind of rotation we call them as anterior posterior rotations, right. So, these two rotation yields something, that is what we are going to talk about. Now, this is what we are talking about. There are two sides of rotation which is kind of like a unit for the stomach development. The rotation of the stomach taking place, we take one rotation at a time and we understand what happens to it. So, this particular longitudinal rotation, we take it first, rotation number 1. That creates a lot of thing, a lot of change in the GI system or entire large region or large cavity that we have, this particular greater sac. Within this particular rotation creates a lot of changes. So, rotation number 1, we focus in here longitudinal axis rotation. So, this axis which is coming above down and there is a rotation of the stomach. So, this longitudinal rotation of the stomach is happening here on this axis and it is 90 degree. So, it has a rotation 90 degree which is taking place and the directions of the rotation over here is clockwise rotation. Now, what do you mean by this? There are two kinds of rotation taking place over here, clockwise and anti-clockwise. Now, see, I am stomach, I have this particular wall, anterior wall, posterior wall. I have two vagus nerves, right vagus, left vagus, placed on two sides of it. Now, I am pierced by a axis which is running longitudinally above down. So, I am taking a rotation which is 90 degree and after this 90 degree in which direction I am rotating? Clockwise. Now, I am making a move like this. and again I am making a move like this. So which one is clockwise? The first one or second one? This one, right? So this one? You're sure? You're awake, right? Sleepy? So I am rotating longitudinally 90 degree. So this is my anterior wall, this is my posterior wall. Posterior wall is more curved than anterior wall. I have two vagus, right vagus, left vagus. Now I make a dancing movement, 90 degree clockwise rotation. So I am facing you right now, I am making a rotation 90 degree. So is it 90 degree? Now I have some changes with this. So what happens with these changes, with this rotation? What happens to the vagus nerves? The vagus is facing you. Now it becomes anterior. This one posterior. So my right vagus becomes posterior. Left vagus becomes anterior. So I have to change the name. So before that it has right and left. Now it becomes anterior and posterior vagus nerves. There is a change. Now coming to the surface. What happens to the surface? This one greater curve. This one less curve. Posterior one is more curved, differentially grown, right? Now what happens to that curvature? The posterior one moves to which side? Left side. Less curved, move to which side? Right side. This is how we see that anatomical position of the stomach placed in. Right curve is on the right side, left curve, this one which is more posteriorly curved, greater curvature on the left side, lesser curvature to the right side. So this one with this movement longitudinally changes two things, more things but two appreciable things. Change of the name of the vagus and curvatures, which is right and left placed in different directions, which is because of the greater curvature and the lesser curvature moving. So this greater curvature moving to the left side and lesser curvature is coming to the right side. So there is a change of this curvature, and so is the surface. So the surface becomes anterior surface, posterior surface, or anterior superior surface, posterior inferior surface. That's why we talked about. So two curvatures, two borders, two mesenteries, two openings, two nerves, etc., etc. This comes with this particular phenomenon. So this longitudinal rotation yields or brings some changes with this. So longitudinal rotation is how much? 90 degree. To which direction? So CW 90 degree brings a change. Change number one is vagus, which is coming over here. Change number two is that lesser curvature and greater curvature goes to different directions. This is what we are happening with these longitudinal rotation. These are the two things that is we have learned so far. Clear or not? Now there is a third thing coming. So what third thing is coming? Now see that. This is the primary position number 8. So we have the stomach, we have this particular ventral mesentery. This is on the posterior side, dorsal mesentery. You are seeing it from above, looking above, and the stomach is placed down there. That's how we are looking. Now what is happening here? Stomach is making a movement. What movement? Clockwise rotation. So this particular stomach is rotating over here and making a clockwise 90 degree rotation, changing the end of the surface of this curvature, and this particular axis right left is moving on. Then what happens with the mesentery on the posterior side? So this particular mesentery which is present on the posterior side, we call them as dorsal mesentery. What happens to the dorsal mesentery? It also makes a movement. So this particular dorsal mesentery makes a movement and creates a space on back side of the stomach. So that particular space created because of the movement of this particular dorsal mesentery, which is anchored to this particular stomach on the posterior side, creates a potential space. That space we talk about, omental bursa. We call them as lesser sac. So this sac is created. So this is phenomenon 3, which happens because of the longitudinal rotation. So omental bursa, which is known as lesser sac, is created because of this particular movement, 90 degree longitudinal axis movement of the stomach. So these are the 3 things that has happened so far. We know there are other things also happening. We are going to discover this as we progress through. So the 90 degree clockwise movement of the stomach brings these changes A, B, C, D, E. These are your MCQ choices except one or all of them or none of them. So, you have to choose through. So, how this omental bursa is creating movement of the stomach, movement of the duodenum, movement of the spleen, etc., etc. So, you have to take the right choices. If you know this, then only. So, this particular region is potential to have a very high yield region for the MCQs. Now, we started with this movement of the stomach, we call them as rotations of the stomach. How much, to which direction, and brings what are these three changes that we have known so far. So, this is what we call them as lysosac and movement of the stomach. We left with other movement of the stomach. What this particular movement of the stomach, we call them as anterior posterior axis. That means stomach is pierced front to back and then it is making a movement. Now, what happens with this particular anterior posterior movement which is happening out here? Once this particular stomach is placed like the way it is placed with this particular longitudinal rotation, it appears or readjusts its position. So, what happens to this? This was staying straight, erect. Now, what happens with this particular anterior posterior axis rotation? It reclines. That means it takes a chill, rest. So, this cardiac end or fundus dips down and the pylorus or this particular lower end moves up as if it leans back. So, this particular upper end of the stomach moves to further left and this pylorus move farther towards the right. That is why this is pushing towards the epigastric region and towards this particular right hypochondric region. So, this fundus goes down farther to the left towards the spleen side and this pylorus moves up. So, this particular rotation creates or readjustment of the final positions of the stomach. Once this particular stomach is placed on here, it gets to rest on the mesentery and the spleen on the back side. This one is placed above. So, it is ready to take tons of foods now because it has a cushion prepared on the back side which is the omental bursa, and it has pressed the head end resting on the spleen and as well as this particular peritoneum folds on this side, and it is taking for absorption and picking up foods now. So, these are the two rotations taking place that we have to keep in mind. The longitudinal one is phenomenal and a lot of information is going to happen because a lot of changes are there. Anteroposterior rotations is final readjustment, is known as reclining of the stomach, because stomach was standing straight, it cannot stand that long because it has to take a lot of food material because it has a capacity around 2000 cc. That means 2 liters of the fluid, 2 kilograms of the food can be absorbed, can be taken at a time. How much you can eat? How much biryani you are going to eat? 3 packs, 4 packs? So, whatever you take, 2 kilo, you can pour in. So, this is about this particular movement of the stomach. 3 of the things which is changing out here with this longitudinal rotation that you have to keep in mind. Number 1, change of the name of the vagus. You are changing the name of the vagus. You remember that. That is not an easy thing. You are changing the name of a city. Kerala becomes Keralam. Bangalore becomes Bangalore. You are changing it. It becomes right to left, becomes anterior to posterior. Remember that? So, you are changing. Second thing, you are creating a space. What space? Omental bursa, which is known as stomach bed, which is created over here. You are changing the surface, curvatures, names of this particular stomach, which is present on this anteroposterior surface, posterior, inferior, or this particular curvature becomes lesser curvature, greater curvature, 2 different directions. So, everything is changing over here. There are 4th thing coming. We will be coming into next organ. We will see there is another change which is bringing to the neighbor organs as well with this longitudinal rotations. So, this much about this particular stomach and stomach rotations which is taking place. Coming to this particular clinical problems related to the stomach. This is about your MCQs or as well as the clinical problems. Out of this, we focus in this particular clinical problem. We call them as hypertrophic pyloric stenosis. Now, you focus in each of the word, you get this particular problem. Hypertrophy, that means there are more muscles are there. Hypertrophy of the muscles are there. Which part of the stomach getting hypertrophy? Fundus, body, pylorus? Pyloric. So, what part of the stomach is pylorus? This part is pylorus? This part. No, not this part, this one, right? This is a pyloric region, pyloric canal, pylorus, pyloric sphincter, everything is there. So this part of the stomach, which is known as pylorus, is creating a hypertrophy. That means muscles becomes more. Creating what? Stenosis. That means, what do you mean by stenosis? Narrow or wide? Narrow. Stenosis means it's narrowed down. So half of the road is broken down into super half. So it is narrowed down. What happens if you have a narrow passage to the traffic? What happens to the traffic if the road, half of the road is broken down? Obstruction of traffic. So what obstruction happens out here? Food. You are taking food, but it's going, passing very slowly. You take how much? How much you can take? 2000 cc. And how much you are taking right now? 1000 cc, and it's not going. It's not clearing quickly. I cannot take more. It's not going to duodenum. It's not going passing. So I am not taking. It's long time. Our bikele khabo. So thing is that we have a hypertrophy of the pylorus. That pylorus sphincter is a anatomical sphincter. It's a strong one. That particular sphincter becomes hypertrophied, leading to the stenosis of the canal, so that food material is going slowly. So this is what is happening. So you get the clinical conditions. We add the word out here. We call this word along with adjective over here, we call them as congenital. That means, who are the individual who are suffering with this congenital hypertrophic pyloric stenosis? Big person like me, or super big like HOD sir, or just born? Just born. So if you have a congenital hypertrophic pyloric stenosis, the young kids, just born, newborns, they have these particular problems. Now what happens to this particular person if they are having this particular symptom like hypertrophic pyloric stenosis, just newborn or newborn, 6 months old? Vomits. The mother wants to feed more. It's coming out. Ekbar hoyni, arekbar. Ekbar hoyni, arekbar. So when it becomes 4 and 5 times, then it becomes alarming. Something wrong. Then it comes to you. And what do you? So this particular thing happens with the kids, young newborn. So we call the word congenital, but it's a misnomer. It's not a congenital. It affects usually the kids who are of near to first decade of first year of life. That means 9 months to 1 year old kid coming with the clinic with the recurrent vomiting. Whatever the food is taking, previously it's fine, doing good. All of a sudden, throwing out all the content, whatever it is taking, and mother is bringing with you. So you have to be suspicious one. এবারে বাচ্চার পটিও হচ্ছে আবার বমিও হচ্ছে, congenital hypertrophic pyloric stenosis, এক্ষুনি অপারেশন করতে হবে, বাচ্চা বাঁচবে না, নিয়ে কোথায় দৌড়াবে, মা কোথায় পারবে না. So not all the cases are like this, but you have to be suspicious about this particular thing, about hypertrophic pyloric stenosis. Could be a possibility in a newborn, just born. You have to seek more, understand more about this particular disease, right? So this is a clinical presentation, but this is not the only clinical presentation that is patient is going to come. So bomi kore patient elei এটা নয়, ঠিক? So this is what we are talking about, is hypertrophic pyloric stenosis. This can affect adults as well. It can affect kids as well. If the kids are affected, we call them as congenital one, congenital hypertrophic pyloric stenosis. Just breaking the names, we can understand how these things are going on. And if you have this particular disease, how we are going to treat that, by the way? If you have a patient like this, coming with this, and you have diagnosis correctly, and you are right in diagnosis, you have done an ultrasound of this upper abdomen, it's showing hypertrophy on the pylorus. What are you going to do next? So I am going to give a green pill first, if it works well. If not, I will take a blue pill, then red pill, yellow, purple, or what? So do you think this stenosis and narrowing is going to be away with pills? Do you really believe? No? So what are you going to do? Find a surgeon. He is going to be surgeon, right? You are going to be surgeon. No surgeon? So what are you going to do? You have to refer it towards the surgeon. We have to cut through this particular point, widen this particular stenosis or narrowing, and create a more spacious region on that part. So this is a kind of surgical emergency. That's what you have to appropriately direct it. Alright, good so far? So what are the types of stomach rotation? Longitudinal axis rotation, anteroposterior axis rotation. Longitudinal one creates a lot of mess. Change of name, change of surface, change of borders, creates a space, lot of mess. Anteroposterior, chill, only reclines, no problem. Okay, how this particular stomach curvature is created? Greater curvature and lesser curvature from a tube. Disproportionate growth of walls of the stomach. Which wall grows more? Posterior one. Creates which curvature? Great curve. Alright, good. Spleen is not a part of GI system development, but it is within this GI system. That's why you have to talk about briefly. Spleen is a reticuloendothelial system. That means it's related to the blood system, but it's present in the GI tract. That's why, or GI system, that's why you're going to talk about. Spleen develops as a mesenchymal or mesodermal element present within this particular dorsal mesogastrium. What do you mean by the dorsal mesogastrium, by the way? We have two kind of mesentery attached to the stomach. Remember, this part we call them as ventral mesentery or mesogastrium. Posterior one we call them as dorsal mesogastrium. Dorsal mesogastrium is the thing which is present throughout this one. This one becomes this particular greater omentum. This one becomes lesser omentum. But this within this particular part we call them as dorsal mesogastrium. We have a migration of mesenchymal tissues or mesodermal tissue gets in pieces, and that particular in piece mesenchymal element slowly develops and condenses. That particular developed condensed mesenchymal element creates this particular reticuloendothelial organ. We call them a spleen. So what happens to this particular dorsal mesogastrium? We have this particular dorsal mesogastrium present in this particular picture. This one. So this particular mesogastrium behind the stomach we call them as dorsal mesogastrium. So within this particular dorsal mesogastrium we have a mesodermal tissue getting in, just like the stomach got inside this particular part, this mesodermal tissue got inside this part. Now this particular mesodermal tissue comes in pieces and then coalesces, joins and forms this particular spleen. Now resulting in this dorsal mesogastrium split into two parts, a part between stomach to this particular spleen and a part spleen to the posterior body wall. Clear what I am trying to say? So what happens over here? Liver, we had no liver before. We have no liver before. We have the liver develops in here. We have this particular ventral mesentery divided into two parts, falciparum ligament, lesser omentum. So likewise this dorsal mesogastrium is pierced by the tissue which forms the spleen. So within this particular stomach and this particular posterior body wall we have a spleen. Creates two things, stomach posterior wall or this particular greater curvature to the spleen, there is one part, and other part between this particular spleen to this posterior body wall. So this is what it is splitting into this particular posterior mesentery of the stomach, which is known as dorsal mesogastrium, into two parts. This part which is present between this particular stomach and the spleen we call them as gastrosplenic ligament, and a part which is between this particular spleen and the posterior body wall or the kidney region we call them as lienorenal ligament. These are your MCQ questions. So how these particular things are developed within this particular which mesentery? It is kind of like the posterior mesentery behind the stomach. Dorsal mesogastrium is divided by this developing spleen into part 1 and part 2. Stomach to this particular spleen, gastrosplenic ligament, and part of this particular ligament which is present on this side, spleen to this posterior body wall which is having develops later on this particular kidney in here, we call them as lino-renal ligament. The kidney was not there before. Kidney comes down from the above. So that's why initially it was only body wall. That's why you call them as lino-renal ligament, which comes into posteriorly. So this is how this particular spleen splits this particular dorsal mesentery in this particular posterior part. So this is two part of the story of the development of the spleen. Spleen is developed in lobules. If you just like remember this, or if you when you study the spleen, you will see that spleen looks like this, notchy, like this. So this particular notchy appearance of the spleen is because it comes in pieces and they join and creates this particular spleen like this. Looks like a comet, or looks like a kind of like a piece of thing which have got a lot of nodules, lot of bumps are there. It's because they come from different regions, joins and forms these things. Where from they are coming from mesodermal element. Where from the GI system is coming from endoderm. So there are two different entities which is present in here. So that's what you have to keep in mind, why this particular spleen is lobulated. That's I explain why. Origin of the spleen is coming from in pieces. That's why they come in here and creates this particular kind of spaces, lobules like this, A, B, C, D, E, F, G, and they joins like this and creates a lobulated spleen. So this is what we have done. Now talk about big thing. You want a break, 2 minute, 3 minute breaks? You take a break, because we are going to talk about this particular development of two heavy things, liver and gallbladder. Liver and gallbladder, if you have an understanding of this particular histology of the liver, that would have been easy. If not, I'm just like breaking it down, this particular histology of the stomach. Then we'll talk about this embryology. It will be easy for us. So the liver have a capsule. Liver have cells. We call them as hepatocyte. Liver have a system, we call them as sinusoids, which is a vascular channel system. Liver have within this, it has a other cells than hepatocytes, we call them as defense cells. And liver have other things which we know that lobes of the liver, falciform ligament, caudate, quadrate, etc., etc. It has dual blood supply coming from the hepatic artery. It is coming blood from the portal vein system. Two systems is coming, enriching the liver, giving the blood supply to it. So this is about the liver. Now we are going to talk about the development of the liver, which is related to one mesodermal entity that will be coming in here. We call them a septum transversum. So frequently we will be using this particular word septum transversum, and this septum transversum will be coming again in terms of development of the pericardium, development of the diaphragm, etc., etc. Septum transversum. So these words will be coming here. We will be explaining what we are going to talk and how these particular things are going to contribute in case of this liver development. Alright. So if you break down liver histologically, other than this particular gross anatomy of the liver, you are going to see these particular things. Liver have a covering capsule, we call them as Glissen's capsule. On top of Glissen's capsule, we have a peritoneum covering, we call them as visceral peritoneum. Deep to that, we have the cells, we call them as hepatocytes, hepatic cells. Then we have this particular network of this particular vascular system, which is breaking down to the liver into it, we call them as sinusoids, where this particular blood comes in and goes through the hepatocytes. We call them as hepatic sinusoids. then it has defense cells which is combating this particular liver diseases which is related to Kupffer cells, etc., will be there, which are different types of cells which are present in here. So, all these different elements of the liver, we have to grow into a single liver that is existing in it. So, it is a complex system to develop to. So, to start with this development of the liver, we see and focus back to this particular entity. We have this particular tube. This particular tube we call them as primitive foregut tube. Now, this particular primitive foregut tube, we have developed a stomach there, and beyond the stomach it is going down. That means it is a distal part of the foregut. That means foregut tube which is going to end soon. So, that ending part of the foregut tube, which is point here, is showing a bud or outgrowth. That particular bud in black you are seeing here. This particular black shadow in this particular schematic picture A we are seeing here, which is a developing embryo near the 4 weeks of life or 4.5 weeks of life. You see here this black shadow. That particular black shadow is coming from the yolk sac tube. That particular yolk sac tube which is known as primitive foregut tube. That particular primitive foregut tube we have learned from esophagus, we have learned this part has developed stomach, and then bottom end of it creates a outpouch. That particular outpouch in the black we call them as liver bud. It is going like blossom, that is why you call them as bud. Now, this particular bud is getting bigger and bigger. As it is getting bigger and bigger, it gets a mesenchymal tissue in here. This particular mesenchymal tissue in the brown or orange that you are seeing here, we call this mesenchymal tissue as septum transversum. Now, this septum transversum separates the developing heart from this lower mesenchymal tissue. So, it is a kind of heart needs to be developed separately so that it is guarded from the other structures, and a tissue develops here which call them as mesenchymal or mesenchymal tissue which develops in here, we call them as septum transversum. As the liver bud grows in here, it grows into the septum transversum. Now, what is the septum transversum? Septum transversum is a mesenchymal tissue. That means it is developed from mesoderms. So, this septum transversum is a kind of like a tissue, bridging tissue. It is pierced by some blood vessels. We call them as vitelline veins, umbilical veins. It is coming from the placental ends, lower ends of the body, piercing here and eventually going to the developing heart. As you can see, it is going to the heart. So, this particular septum transversum is a mesenchymal tissue which is kind of present at the developing heart or the bottom end of it, and blood vessels from the lower part of the developing embryo is piercing up and passing through the septum transversum and used to go to the heart or future heart. This is how this particular septum transversum was there. Now, this particular septum transversum has a new problem. What new problem? It was there, no problem was there, as it was pierced by blood vessels getting the blood to the heart. Now, what happens here? We have a new organ is developing. What organ is developing? The future liver has to develop. How the liver develops? From this particular gut tube, the foregut tube. Which part of the foregut tube? Lowermost part of the foregut tube. How this particular liver is growing? As a outpouch. We call this outpouch as bud. This bud we call them as hepatic bud. Now, what happens to the hepatic bud? It gets the septum transversum and it penetrates it. So, this particular architecture of this particular septum transversum is grossly overtaken by the liver or hepatic bud. So, this particular liver from here is growing like a bud initially from this gut tube, gets this particular thing and encroached over here like this, and it grows within the septum transversum and dismantles the septum transversum and takes it all. Whatever the blood vessels was there, whatever the mesenchymal tissue is there, it's all taken by it. It is engulfed by it and used by it. That is how this particular liver is going to grow. Alright. So, slowly we learn it. So, this black tissue was the thing which you are talking here. We call them as hepatic bud. The hepatic bud growing into what? Septum transversum. As it is growing in the septum transversum, it completely takes the architecture of it and grows within it and takes all the septum transversum tissues, whichever it can take it within this system, and takes it on its own and makes it for its own development. So, this particular liver bud initially was small bud like this. You see picture number B. With time, 3 days, within this septum transversum is black tissue has grown more. That means liver tissue has grown more. This particular black tissue which you are seeing here coming from where? This endodermal tube. This black tissue is growing more like this. So, this particular connection of this particular tube, stomach has developed this primitive foregut tube. This is what is going to this lower end of the primitive foregut tube, and you see a bud is growing like this, which is growing within this particular septum transversum. And you see the narrow connections between this particular primitive foregut tube with this particular bud becomes a duct like this. So, this is how this particular liver is growing within this particular septum transversum, and within this particular septum transversum the liver takes it all the blood vessels, all the mesenchymal elements from this liver buds are taken up and broken down into this. This particular septum transversum used to pierce by the blood vessels. What are the blood vessels were there? Umbilical vein, vitelline veins. There are two sets of there, two pairs of them. What happens to them? These veins was there intact. Later on, what happens? As the liver grows, it takes out all and breaks it down into small channels like this. These small channels which is present in here, we call them as hepatic sinusoids. And this particular hepatic sinusoids becomes its own system. So, this is how the liver is growing into the septum transversum, takes all the structures, and this is how it is growing on. So, liver cell hepatocytes, where from it is coming? It is coming from this yolk sac endoderm. So, yolk sac, that tube, that primitive gut tube had the endoderm. So, that endoderm cells becomes hepatocytes. Who forms the sinusoids? Septum transversum plus vitelline veins remnants plus umbilical vein remnants. So, these hepatic sinusoids are created from this septum transversum as well as vitelline veins and as well as umbilical veins. Defense cells, where from these defense cells are there. There are two types of defense cells are there. One of them is known as Kupffer cells. Where from they are coming? They are septum transversum. So, septum transversum is giving these defense cells to it. All the weapons are coming from this septum transversum. Capsules of it. This particular capsule, liver is covered by a capsule which is present in here. This capsule also is taken by the septum transversum. So, basically it has only one thing for it, the cells. What cells? Hepatic cells. That cells which is known as hepatocytes. That was its own. Rest of this taken from where? Septum transversum or content of the septum transversum. Whatever is taken is all mine now. This is how the liver is growing. From a bud, it engulfed this particular entire septum transversum, transformed the septum transversum into its own system and develops this particular livers into a wholesome liver. So, liver is composed of this particular element. It has a capsule, it comes from septum transversum. It has a special cell, we call them as defense cell, Kupffer cell. Where from it is coming? Coming from septum transversum. It's coming from this particular sinusoids, venous system, channels, everything there, biliary canaliculi, channels. Where from it is coming? It is coming from septum transversum blood vessels, vitelline vein, umbilical veins. So, it has only one thing, hepatocytes, liver cells. How do the hepatocytes looks like? It looks like hexagonal. So, these only hexagonal things, its only own. Rest of these things are taken. Clear? All are your MCQ questions. You don't have to know about how these particular things grow slowly becomes trees. No, you know what are the fate of these things, what comes from to what, right? So, these Kupffer cells are coming from development cells, what? Sinusoids coming from where? Hepatocytes coming from where? That's what at the end of the day you have to remember these things, 1, 2, 3, 4 things, and these are could be your MCQ questions, right? You do not have to memorize the whole story of liver development. Only thing you have to know this thing. But this thing doesn't stick to your brain unless you know the story. Alright, so this is about it. We stop it at here.